In this video, we are going to cover flowcharts and tables from the topic of mitral regurgitation. So starting with table 1, major causes of mitral regurgitation. It is further divided into acute MR and chronic MR. The causes of acute MR are infective endocarditis, papillary muscle rupture because of myocardial infarction, and the most common being inferior wall MI. The other causes are caudal rupture or blunt trauma. And in the chronic MR, it could further be divided into primary MR and secondary MR. So, what is mitral wall apparatus? So, this is left atrium and this is left ventricle. So, this is the mitral wall, this is cauda tendineae, this is papillary muscle, and here it is the surrounding myocardium. This is the surrounding myocardium. So, the mitral valve apparatus includes the mitral valve, cauda tendineae, papillary muscle, and the surrounding myocardium. So, if the leaflets or chordae are involved, this is known as primary mitral regurgitation, and if the myocardium or papillary muscles are involved, then it is known as the secondary mitral regurgitation. The causes of primary MR are myxomatous causes like the mitral valve prolapse, also known as the Barlow's disease. This was asked in this year's NEET SS exam, or forme fruste. Or it could be because of rheumatic fever, healed infective endocarditis, congenital causes like the cleft or AV canal, or radiation. And the secondary causes includes ischemic cardiomyopathy or dilated cardiomyopathy, because in dilated cardiomyopathy the left ventricle size increases, and because of this the annulus ring increases, and this leads to mitral regurgitation. It could be HOCM or atrial fibrillation with left atrium enlargement. In left atrial enlargement also the annulus increases, leading to functional mitral regurgitation. And the other cause could be mitral annular calcification. Now talking about the severity of mitral regurgitation. So here also you should only remember the severe MR, and how I used to remember is, you should remember 4, 5, 6 and 7. So what is it? In severe MR, the effective regurgitant orifice area is more than 0.4 centimeter square, and the regurgitant fraction is more than 50%, and regurgitant volume is more than 60 ml, and vena contracta in case of MR is more than 0.7 centimeter. So this is how you can remember the severe MR. Okay. And apart from that, if you want to remember the mild and moderate case, so in mild case, EROA is less than 0.2, regurgitant fraction is less than 30%, regurgitant volume is less than 30 ml, and vena contracta here is less than 0.3 centimeter. And for moderate case, it is in between 0.2 to 0.39. Regurgitant fraction means 30 to 49 percentage. Regurgitant volume is 30 to 59 ml, and vena contracta is in between 0.3 to 0.69 centimeter. So only remember the severe MR, which could be remembered by 4, 5, 6 and 7. Now after this, let us see the staging of MR. So like all the cases, it is same, stage A, B, C and D. Stage A refers to patient at risk of developing MR. Stage B is patient having progressive MR. It could be mild or moderate MR. And stage C is severe MR, and stage D is also severe MR. But stage C, patient is asymptomatic, and in stage D, patient is symptomatic. And stage C could further be divided into stage C1 and stage C2. In C1 stage, the ejection fraction is normal and it is more than 60%, and end systolic diameter is less than 40 mm. So you know, in mitral regurgitation, you cannot rely on ejection fraction as the marker of contraction of ventricle, because in regurgitant lesions, so suppose if this is left ventricle and this is left atrium, so here during contraction the blood goes in atrium, left atrium, as well as in the aorta, right? So after the contraction, how much blood that is remaining in the left ventricle, that serves as a better marker of the contraction of the ventricle. So after the contraction, if the blood which remains is less than 40 mm or less than 4 centimeter, it means the contraction is good. So the C1 is ejection fraction more than 60% or ejection systolic end systolic diameter less than 4 centimeter or less than 40 mm. And C2 refers to ejection fraction of less than 60% or ESD of more than equal to 40 mm. And stage D is symptomatic severe MR. Now coming to the management part. So the management has been divided into two based upon whether it is primary MR or it is secondary MR. So first we will see primary MR. So this is the criteria of severe MR. Okay, 4, 5, 6 and 7. So if the patient is having severe MR, then patient could be symptomatic. It means in stage D, or patient could be asymptomatic, that is stage C. And if the patient is symptomatic, it means patient should undergo mitral valve surgery. Alright. And if the patient is asymptomatic, it means the patient is in stage C. So there, if the patient is having stage C2, then also you will directly perform mitral valve surgery. And if the patient is in stage C1, then the patient will undergo severe serial monitoring. And during monitoring, if the LV ejection fraction decreases consecutively in the 3 studies, or if there is low risk of the surgery, then you can go for mitral valve surgery. That's it. And the remaining one you do not need to remember. Now coming to secondary mitral regurgitation. So here the first thing that you should do is to give GDMT, that is goal directed medical therapy. So in the question it will be given that the patient is having severe MS, what is the next step that you have to follow. So there you do not need to undergo surgery directly. You will give the medications, that is GDMT, to the fullest, and if still the patient is symptomatic, then only you have to perform the surgery. So GDMT includes beta blocker. Apart from that, there would be diuretics, then ACE inhibitors, then and ARBs, and apart from that, spironolactone and aldosterone antagonist. So first you will give GDMT, and after GDMT, if still the patient is having severe MR stage T, it means the patient is symptomatic, and then you will also do angiography in this patient, because the causes is secondary, like the patient could be having myocardial infarction, that is the cause. And if the patient is needing CABG, that is other cardiac surgery, then with that CABG only, along with that you will also perform mitral valve surgery. And apart from that, if the patient is not having any vascular lesion and you find that the patient is having ejection fraction of more than 50%, okay, or other thing is ejection fraction is less than 50%, and in both, if the symptoms are persistent after GDMT, then you will perform the mitral valve surgery. Okay, if the mitral valve anatomy is favorable, then you will perform transcatheter H to H mitral valve repair, and if not, then the patient will undergo mitral valve surgery.